Hi everyone, welcome to Dublin. Thank you all for being here. Special thanks to Professor Bloom and to the Ehlers-Danlos Society for inviting me here. I'm very excited to be able to share some of my research with you. Some brief background about myself. As was mentioned, my name is Colin Halverson. I'm a researcher at Indiana University in the United States. I'm faculty in the Center for Bioethics there. I have a bit of a unique background. I have a Ph.D. in Medical and Linguistic Anthropology from the University of Chicago. Through a roundabout way, I found myself for the last 10 years working on trying to find ways to better improve how we care for patients with rare disease. Since starting at Indiana University, I had the wonderful serendipitous experience of beginning at the exact same time as Dr. Claire Franco-Mano. And so together we've been collaborating on a series of studies with patients with hypermobile Ehlers-Danlos syndrome. And it's some of that research that I'm going to be presenting today to you all. Let's see, as mentioned, the focus of this talk is one specific aspect of that research, which my co-authors and I have called clinician-associated traumatization. I technically don't have any disclosures relevant to this specific talk, but I do, oh, I got too far. But I do want to mention in any case, well, we don't need that slide. In any case, that the reason that I'm able to continue to do the research over the last year and a half is because I've received a career development award from the National Institutes of Health in the United States. And so while that doesn't directly impact the data that I'm presenting today, it is the reason that I've been able to continue doing this type of research and will continue doing it going forward. The other piece of information that was on that slide is that if you look at the bottom, not here, but on many of the slides, I do have the relevant citations. For instance, much of the data I'm presenting here today is from a publication appropriately titled Clinician-associated traumatization in the Journal of Social Science and Medicine. That is open access. Many of the publications you'll see are open access. It's something that I feel is very important as a way of getting research out to people who don't have access to a university library and similar institutions. The objectives of my talk today are, first and foremost, for the clinicians in the room to be able to characterize sources of clinician-associated traumatization. I think this is important, especially because a lot of the things that end up being triggers for this type of trauma are not necessarily obvious to the clinicians themselves. Then the core of my argument today is that I hope to demonstrate, as Professor Bloom mentioned, the direct relationship between these types of negative encounters that patients have with their clinicians and the worst health outcomes that they experience afterwards. And finally, the slides are, okay, there we go. Finally, I hope to suggest some types of techniques that clinicians can use to avoid re-traumatizing patients in their own practices. Let's see, so then outline of the talk, I'm going to begin with a vignette from the average life of a patient with HEDS based on the interviews that I've conducted. Then I will turn to how we came to recognize this type of trauma is so central to the story of many patients with HEDS. I will look at the background for this ongoing series of studies that I'm conducting with patients with HEDS and other forms of EDS, and then also specifically the methods for this particular study looking at trauma. Then I will compare and contrast our construct of clinician-associated traumatization with already described forms of trauma and why we believe these two forms are actually different. And then we'll look at the effects of a CAT, as you can abbreviate it, on both patients' mental and physical health. I think, actually, I wrote that there's going to be time for questions. We'll probably have to save that until later. I do want to provide a content warning for everyone here. I'm going to be talking in some detail about these types of negative experiences patients have had with their clinicians. I'm deeply aware that that can be challenging to listen to if you have experienced these types of encounters yourself. It is very reasonable if you want to step out, take a moment, not hear these stories right now. I'll give you all a moment if you'd like to. I'm not going to be offended. Everyone recognizes that this is a real issue that people have experienced. I will also mention that all of this is being recorded, and so if you do choose to step out now, you're not necessarily missing this altogether. You can come back and watch it online, perhaps at a time where you feel more comfortable, or in a space where you might feel more comfortable as well. I'll give everyone a moment if they would like to step out, because the next thing I'm going to discuss is this vignette. All right, so this is a story of a patient with hypermobile Ehlers-Danlos syndrome. It's not the story of any one individual. It's an amalgamation of stories that I've heard over the last 4 years. So imagine this. You're 16 years old. For over a year, you've been experiencing debilitating pain on a daily basis, to the point that you're only attending school part-time. When you aren't at school, you spend a lot of your day in bed. Your friends don't understand what's happening to you, and they start to drop by your house less and less often. You feel isolated. Your parents are frustrated. They don't understand you either. They take you to the hospital to try to figure out a way to stop the pain. Your pediatrician sends you to this specialist and that specialist. Your parents drive you 4 hours to see a doctor in a completely different region. When you get there, this new doctor says there's nothing he can do for you. You just have to learn to live with the pain. He tells your parents you're depressed and should see a therapist. Over the next month, you see 3 more specialists. Finally, the last one, an orthopedist, tells your mother that you're exaggerating your pain. He thinks some of it may be unconscious attention-seeking, or that you're trying to avoid school. It feels like he's saying your pain isn't real, the pain you feel every day, the pain you're feeling right now. You start crying, even though you worry this will further cement his belief that you're just being over-emotional. You stay in your room most of the next day. Later, your mom says she's found a new specialist online who can see you the next week. You feel your heartbeat begin to race, and you get nauseous. You tell her no, you refuse to see another clinician, but your pain only keeps getting worse. I can imagine that this story resonates with many of you. Like I said, this isn't the story of one specific individual. All of these features of the story were told to me by patients over the course of the interviews that I've been conducting. I did not select these stories because they were particularly salacious, though. In fact, I chose them for the exact opposite reason, because they are so common. So how do we come to recognize, I'm going to figure this out by the end of the talk. How do we come to recognize this type of trauma as so central to the stories of patients with HEDS? When I started my research at Indiana University, collaborating with Dr. Franco Mano, we began by gathering a cohort of 40-some patients who I've followed over the last 4 years, conducting a number of different studies. But we began this research with a series of interviews about patients' diagnostic odysseys, meaning the time period between when a patient is first begins seeking a diagnosis and when they finally receive that diagnosis. In a later study that we did as a survey through the Ehlers-Danlos Society's global registry, thank you everyone who's enrolled in that, we had over 500 responses from around the world, and we found that the average length of time to diagnosis is over a decade long. It was incredible seeing everyone standing up just a moment earlier. It really is an exceptionally long amount of time, even by the standards of rare disease. So through these, in the analysis of these diagnostic odyssey interviews, we were able to identify a number of topics that we thought deserved further research. And since that time, we've done interviews related to patients' recommendations related to complementary and alternative medical techniques, the use and utility of social media, and how patients manage to communicate pain with their clinicians. One of the things, though, that kept coming up in these stories was the experience of clinicians' disbelief when a patient was describing his or her symptoms. Patients told me that they felt an intense and depressing amount of invalidation from their visits to clinic. Through analyzing these data, we were able to identify specific features of HEDS that correspond to the clinician's disbelief. First and foremost among them is the experience of chronic pain itself. Through the survey, we found out that chronic pain is actually the #1 reason by leagues that patients begin to seek a diagnosis. We also know that pain is a private experience, meaning that no one else can feel your pain for you. In medicine, we call this a subjective symptom, meaning that there's no purely objective way for a clinician to assess or evaluate a patient's pain. They have to rely, at least in part, on the patient's self-report of their experiences. This can be a particular challenge to clinicians who may find it hard to trust their patients for a variety of reasons. This is coupled with the fact that the pain patients with EDS experience is not acute, rather it's chronic, and clinicians are generally trained to recognize signs of acute pain. Through our conversations with patients about their experience communicating pain, we found that over the course of a lifetime living with this symptom, patients actually adapt to their pain, adjust to their pain, and not only do they begin to describe their pain differently, they actually begin to experience their pain differently as well. Therefore, clinicians who are looking to validate patients' pain on the basis of an understanding of what acute pain looks like may miss the symptoms as they present in patients with chronic pain. Moreover, Ehlers-Danlos is what many people consider an invisible disease, meaning that it is primarily not something that you can recognize merely by looking at the overt signs of the patient's experience. Additionally, many patients I've worked with said that they've gone to incredible lengths to present themselves in clinic as a credible patient and a good historian. This is related to the awareness that clinicians oftentimes dismiss patients as they try to describe the experiences that they've had. And so patients have told me that when they go to clinic, they try to present themselves as well as possible, often dressing up, wearing makeup. And one of the things that we found most frequently in our pain interviews is that patients more often than not downplay their symptoms rather than even describe their symptoms in a way that feels accurate to them. So this ends up being a double-edged sword, though, as clinicians then encounter a patient who looks and presents him or herself in a way that they're completely not expecting for someone who's experiencing such acute pain. Through the interviews, we came to recognize that patients were being labeled difficult by their clinicians. This is one of the things that made us recognize this sort of trauma as perhaps the most important feature of the Diagnostic Odyssey interviews and deserving of further research. We know from the literature that being labeled difficult results in worse patient experiences in clinic, greater patient dissatisfaction, premature discharge from the hospital, inappropriate referral to psychiatry, and what's referred to as blacklisting. Blacklisting means when a clinician decides they no longer are interested in seeing a patient, they may make a note of this in the patient's health record. This is a problem for patients not only because it means that they are unlikely to be able to continue to see that particular clinician. These types of blacklisting notes can circulate through the doctor's social network and can affect the patient's ability to find care with many other clinicians as well. In our interviews, I was told by several patients, though a minority, that they'd been given a PTSD diagnosis due to their experiences with healthcare. In the survey that I referred to earlier, we found out that actually a full third of patients with HEDS have received a PTSD diagnosis at some point over the course of their diagnostic odysseys. While that is a minority, it's certainly a significant minority. The problem, though, for us was that while a handful of the patients we spoke with had a PTSD diagnosis, all of the patients we spoke with had some trauma-like responses to the care that they'd received or lack of care that they'd received in clinic. This was particularly worrisome to us because we know that trauma symptoms both exacerbate and are exacerbated by chronic pain, making patients with Ehlers-Danlos syndrome and other forms of chronic pain syndromes all the more vulnerable to this type of bad treatment. So this led us to conduct a series of interviews specifically focusing on patients' traumatic encounters with their clinicians. From our cohort of 40-some individuals, I randomly selected 26 to complete this specific trauma-focused interview. Like I said, I selected these individuals completely randomly. I did not choose them because they'd had particularly negative encounters with clinicians, so that was not a source of bias for our data. I do want to mention two potential sources of bias, though. While the stories that we heard through this study were certainly harrowing, we may have missed some of the most acute stories for two reasons. So if you look at the table on the slide right now, I've got the demographics of our cohort. If you're familiar with what EDS looks like, or HEDS specifically looks like, in general, you know that this is fairly representative of the demographics of patients who have managed to find an HEDS diagnosis overall. However, there's a very high percentage of white participants in this study. We did not hear from many patients who identify as non-white. And this is a potential source of bias because we know from the literature that non-white patients are more likely to have worse encounters with their clinicians and are less likely to have their pain taken seriously. The other potential source of bias for our study is that we recruited patients only from the Ehlers-Danlos clinic at Indiana University, meaning that all of our participants were continuing to seek medical care from a biomedical institution. I'm very aware that for patients who have had these types of negative encounters with their clinicians, that it is often not a viable option for them to continue to pursue care in a hospital setting. And so for patients, so we did not hear from patients who had had such negative encounters that they'd quit seeking care from clinicians altogether. Now to turn to the results of this study. We found that 85% of the participants in our interview study could immediately identify one or a small number of discrete events in clinic that they linked directly to their trauma-like symptoms. However, as I mentioned earlier, every single one of our patients experienced some type of trauma-like response and had had negative encounters in clinic. It's just that the remaining 15% said that it wasn't so much one particular encounter, but this never-ending accumulation of negative experiences with clinicians. The majority of the patients told us they'd felt disrespected, invalidated, and abandoned by their clinicians at least at some point over the course of their diagnostic odysseys. So I am not a mental health specialist, but we did consult with psychiatrists and psychologists both in constructing our interview guide and in the analysis of the interview guide. That was important to me because I wanted to make sure that we were understanding the science behind what we were trying to capture with the study as well. What we found was that the symptoms experienced by patients in our cohort strongly paralleled the symptoms experienced by patients with what I'm referring to as PTSD, kind of broadly referring not just to the DSM-5 category, but also to related trauma constructs such as complex PTSD and medical trauma. And so we found these strong parallels with the PTSD symptoms, but we did not find the same sources of that trauma. And so while PTSD classically is defined by hyperarousal, we found in our population the expression of fear, shame, anhedonia, and exaggerated negative beliefs. In PTSD and related constructs, you see an avoidance and numbing to triggers, and we found an avoidance of clinical settings and avoidance of specific clinicians. And finally, the third classic feature of PTSD is flashbacks, and this was probably the most frequent thing that we found in our interviews, patients experiencing unwanted intrusive thoughts and emotions related to their negative encounters in clinic. So, like I said, the reason that PTSD did not seem to sufficiently capture the experiences of our patients, all the while they were experiencing these types of trauma-like responses, was because for PTSD and related constructs, to have a diagnosis, you need to have a trigger of a sudden, unexpected, and potentially lethal event. While this was certainly the case that some of our participants had experienced this type of brush with mortality, it was not the case that all of them had, and yet all of them did have these experiences. And like I mentioned, this did not seem like it was the source of their trauma. It was not the memories that they kept going back to. Instead, what we found with CAT was that the trauma-like symptoms came from the cumulative compounding negative encounters they'd had in interactions with their clinicians in the hospital. As we began to analyze the qualitative data from our interviews, we found that CAT had both negative consequences for a patient's mental and physical health. From our survey, we found that the most common comorbidities for HEDS are, in a huge percentage, anxiety and depression. We additionally asked all participants in the survey to let us know whether they believed, after getting an HEDS diagnosis, whether diagnoses they'd received previously during the course of their diagnostic odysseys still held as accurate descriptions for their health from their perspective. And what we found was that both anxiety and depression were both highly endorsed by participants as well. And this is surprising because it was not the case with any other mental health conditions. Through a cluster analysis, we also found that anxiety and depression were very closely correlated, meaning that if you receive a diagnosis with anxiety and have HEDS, you're much more likely to also receive a diagnosis of depression. To a lesser but still significant extent, we also found a correlation with PTSD. This is worrisome because chronic pain heightens anxiety and related mental health concerns, and you can certainly imagine the effects of CAT being among those. And this ends up being a part of a negative feedback loop where pain exacerbates anxiety and the reverse. And as promised as kind of the core argument of this talk, we also found an immediate correlation with negative physical health outcomes as well. 81% of our participants told me that they'd experienced a negative health outcome due to inappropriate care that they'd received in clinic. 85% told me that they'd avoided specific clinicians, and then a separate 85% told me that they'd avoided clinical care altogether, at least at some point over the course of their lives. This is incredibly worrisome because for patients who experience ongoing health conditions, many of which may require the participation of a clinician for the patient to experience their best possible health, stopping to seek medical care altogether, while certainly understandable, can have really dire consequences for patients. 68% of my interviewees also told me that they'd avoided disclosing their HEDS diagnosis to their clinicians. This was because they worried that clinicians may harbor a fear, a stigma or bias against patients with that diagnosis. While that's also certainly a reasonable fear to have, not disclosing a rare connective tissue disorder to clinicians may mean that they end up recommending health-seeking behaviors that are actually completely inappropriate for these patients as individuals. One of the examples of this that I heard very frequently was a physical therapist who ends up recommending movements for their patients that are actually more harmful than helpful and can cause further subluxations and dislocations. So all of this hopefully demonstrates the very real physical health outcomes of this type of trauma. I do have a few suggestions for steps to avoid re-traumatization if you're a clinician in your own practice. These are all based on conversations that I've had with patients about what seems to help them and what makes a clinician good from their perspective. The first and most common of these is the practice of empathic speech. Pay attention to your patients' emotional lives, not just their physical symptoms. Treat them as humans and individuals, not just as tasks. This will improve patients' trust in you as a clinician and will also build the therapeutic alliance. Additionally, this will not just benefit the patients. It's been shown that greater empathy reduces professional stress and burnout, and so this type of behavior will also benefit the clinician as well. The second of these suggestions is to take advantage of your patient's expertise of their rare-ish syndrome. It's not surprising that clinicians oftentimes don't know much about Ehlers-Danlos syndrome, but it is surprising just how much patients do know about their diagnosis and their bodies. Treating your patient's knowledge seriously can lead potentially to better informed medical decision-making and will improve a relationship that we have seen over the course of this talk is often very strained. My final suggestion is just based on anecdote. The first two of these are strongly supported by the literature, but through these interviews, I found two patients told me that trauma therapy had been incredibly useful for them in managing the symptoms that they experience as a result of their bad treatment in clinic. One woman even told me that it was only through trauma therapy that she was able to have the conversation she had with me in our interview. Even just a year prior, she wouldn't have been able to get through that conversation without breaking down in tears. I also have a hat tip to Dr. Levi's upcoming presentation at this conference. She's going to be speaking about tips for how to better communicate with patients who may be experiencing CAT. Finally, one last limitation of my study is that it was based solely on the stories of patients with hypermobile Ehlers-Danlos syndrome. Unfortunately, there are very few studies that have looked at the experiences of patients with other forms of EDS. I'm trying to rectify that at the moment by running a series of interviews with patients with other forms of EDS. So if you are one of those patients or you know one of these patients, either a loved one or one of your patients in clinic, please do reach out. I would love to hear your stories as well. I've got my email on the screen here. Shoot me a message and we'll find a time for the two of us to chat. We can do that over the phone, over Zoom, or we can even do it as a series of email exchanges if that's the way that would be most comfortable for you. Thank you very much for your attention. I really appreciate this opportunity. I would like to acknowledge all of my wonderful support throughout my study, including Dr. Claire Franco-Mano, my mentor, my postdoc since the beginning of my Career Development Award, Dr. Tom Doyle, my former research assistant, Heather Penwell, who's gone on to do her own research, and of course, all of the wonderful participants. Thank you so much for your attention, and I look forward to seeing you throughout the rest of the conference.